Hello and welcome. I'm Freya Rigtrink, the Executive Director of the Policing Project. Today's webinar is part of the Policing Project's Reimagining Public Safety Initiative, and we're putting this on today with two co-hosts with the Vera Institute of Justice and the Council of State Governments Justice Center. The Policing Project's Reimagining Public Safety Initiative is an expansive effort to learn about and support jurisdictions that are redesigning their public safety systems in ways that are more responsive to communities, with a particular emphasis on alternative or non-police responses. This project grew out of something we were hearing consistently from the communities we work with, that our system of emergency first response wasn't working for police officers or for community members, and that there was a better way of meeting people's basic and most urgent needs. We've been looking at a wide range of approaches to various community safety needs where a police response isn't needed or not well matched for the problem. And we've done research in several cities around the country and have been creating guidance for cities available at our website, safetyreimagine.org. We've started up this community of practice to talk about important issues that are arising in the area of alternative response, bringing together different stakeholders from across jurisdictions and across disciplines to have important conversations. One thing that has become clear is that we're really at a pivotal moment in this field right now. And many programs have passed the proof of concept stage and are looking to become sustainable and scalable over the long term. And with that, one of the most important questions is, how do we fund this work beyond the pilot stage? Today, we'll be hearing from experts and practitioners about a couple of important funding streams that can support non-police response programs, and in particular, where there's a health-related response. We'll be primarily focused on Medicaid, and we'll also touch on private insurance. We'll be approaching today's conversation in three parts. First, we'll hear about new opportunities that are available via Medicaid. Then we'll talk about how to get started and how that relates to the state-specific nature and framework. And then finally, we'll take a deep dive into a partnership in action in Washington State. First, we'll get started with some introductions. I'll begin with the co-hosts for today's webinar, and I'll go first to Daniela Gilbert from the Vera Institute of Justice. Daniela, could you start us off?
Sure. Welcome, everyone, and thank you so much, Freya. As Freya mentioned, my name is Daniela Gilbert, and I lead the Redefining Public Safety Initiative at the Vera Institute of Justice. Vera's mission is to end the criminalization and mass incarceration of people of color, immigrants, and people experiencing poverty. We work alongside community members, local organizations, and government to develop solutions, test their impact and feasibility, and when successful, scale system change to communities nationwide. The initiative that I lead aims to transform how safety is produced in communities across the country. And as Freya alluded to, the model most common in American communities today assigns public safety responsibilities overwhelmingly to law enforcement and our criminal legal system, which not only fails to produce consistent and sustainable safety, but has also caused harm, especially to Black, Indigenous, Latina, and other people of color. Government agencies and community stakeholders, including those who joined the call today, need and recognize the need for a new way of working together to produce safety, enhance and sustain prevention and response, and invest in support over punishment. Emergency response is, of course, a critical component of public safety, and Vera's research illustrates that nearly 20% of 911 calls could be handled by civilian crisis response teams. In addition to our research on civilian response and the advising and advocacy that we do, we recently published a report on building and sustaining offices of violence prevention or neighborhood safety alongside the National Offices of Violence Prevention Network. And I'll share that link in the chat as well, because a lot of the recommendations are consistent with the needs of civilian crisis response programs and consistent with the research that we did to support equitable implementation recommendations a couple years ago. So we're now focused on bridging these two strands of public safety innovation, and specifically on the creation and sustainability of government infrastructure for public safety that centers civilian and community-based strategies. And of course, these innovations need sustainable funding to take root and truly live up to their promise. And we're excited to support the webinar today, recognizing the emerging and popular interventions relying on Medicaid reflects increasing recognition of the health impact related to our status quo approaches, and we're glad to be able to learn alongside everyone today.
Thank you, Daniela. Next, I'll turn to Sarah Würzberg from Council of State Governments.
Hi, thanks so much. We're so pleased to be partnering on this initiative. So I'm Sarah. I work at the Council of State Governments Justice Center. I lead our Expanding First Response, which is our work to expand community responder programs across the country. That includes a toolkit. We have an Expanding First Response Commission, and we also do direct training and technical assistance to sites around the country.
Okay, thank you, Sarah. And I know we'll be going back to you shortly. But first, I want to introduce our panelists. And so I'll start with Alicia Smith, please.
Hello, my name is Alicia Smith. I'm Director of Policy and Implementation with PEGS Foundation, and I also lead our Clear Pathways initiative, which is focused on ensuring that individuals experiencing a behavioral health crisis are less likely to encounter law enforcement or experience a hospital inpatient stay or emergency department utilization less frequently. My background is in Medicaid, and I started out as a policy and program developer in Ohio, where I still reside today, and have spent the last 24 years as a consultant trying to answer the question of how can Medicaid fund X, fill in the blank for that X related to behavioral health services. Really excited to be part of this conversation today. Thanks.
Thank you, Alicia. And next, can I turn it to Jason Bean-Mortinson?
Sure, thanks. Jason Bean-Mortinson. I'm with Thurston Mason Behavioral Health Administrative Service Organization in Washington State. I've been working in the behavioral health field for about 20 years. The last 10 have been kind of focused on the policy world. And a lot of that work has been related to criminal justice diversion opportunities, working on outreach programs, and some of the programs we'll talk more about today.
Great, thank you. And then Joe Avalos.
Good morning, my name is Joe Avalos, and I am the Chief Operating Officer for the Thurston Mason Behavioral Health Administrative Service Organization, as well as the Administrator for Olympic Health and Recovery Services. And at OHRS, we are a licensed behavioral health agency that currently has multiple partnerships with several law enforcement jurisdictions specializing in civilian response to crisis. And also, we've been successful at billing Medicaid and other fund sources over the last couple of years. So happy to chat and talk to all of you about that today. Thank you.
Great, thank you. Thank you all for being here with us. Really looking forward to this conversation. To get us started and to provide some overall framing, I'm going to ask Sarah from CSG, who's going to lead us through some top line information, some background, and information about new opportunities that are available via Medicaid.
Thanks so much. So we're going to talk about Medicaid and health-related social needs at a very, very high level. This is a super complicated topic. You could spend years, a lifetime trying to understand Medicaid. This is just to frame the conversation and give us some context. So I'll give a little bit of an organizational overview of the organization I work for. I'll talk about Medicaid, and then we're going to specifically focus on mobile crisis and community violence intervention as a piece of this. There's many other opportunities through Medicaid, which we'll touch on very high level, but I encourage you to look at some of the great resources out there through the Center for Medicaid and Medicare Services, which is called CMS. So if you heard the term CMS during this, if I use that term, that is what we're referring to. So the Council of State Governments, we're a national nonpartisan nonprofit membership organization dedicated to research and policy across all three branches of government. We bring people together. We move the criminal justice field forward through policy, research, and expert assistance. We try to break the cycle of incarceration, advance health, opportunity, and equity, and use data to improve safety and justice. The Council of State Governments Justice Center is focused on equity and inclusion through states, communities, tribal nations, and work with nonprofits. We look to dismantle racial inequities in the criminal justice, the juvenile justice systems through research, analysis, and policy decision-making. So to start with the overview of Medicaid. So Medicaid is a joint federal state match program as public health insurance for low-income people. And it is a major source of long-term care coverage in the United States. In 2022, over 90 million people receive services through Medicaid. So you're thinking, why Medicaid? 90 million people is a lot. So this really covers a lot of people in different communities, particularly a lot of people with chronic healthcare needs across the United States. So state and federal match dollars are based on the reported Medicaid expenditures through the federal government for payments made to healthcare providers and managed care plans, and as well as for administrative tasks. So those are kind of the three major things you're able to do. Under the Patient Protection and Affordable Care Act in 2010, states can cover other and expanded low-income adult populations, and the majority of states have done that. There's the federal government does set minimum for income and other eligibilities, but states can choose to go beyond that coverage for the minimums through different variations, which we'll get a little bit into. There's a wide variability to Medicaid programs throughout the states, and there are features and optional benefits that states can cover as part of their service delivery network. So states can pay for providers directly under fee-for-service. They can pay fee for a managed care plan for an enrolled individual, or they can do both. So your state might have one, might have the other, and might have all of those things. So it's really important to look at state-specific information when it comes to Medicaid. There's also additional abilities to test new approaches through Medicaid, through waiving certain Medicaid statutory benefits to really create different opportunities for operations, service delivery, and payment. So a lot of this innovative work we're talking about is through this flexibility to waive different things. So in addition to the healthcare, you can do also other different trends we're seeing is related to value-based payment, which is opportunities to increase paying instead of paying separately for services, increase the outcome and payment mechanisms using quality standards. So there's several different mechanisms you can use for this, and we're not going to go into these in depth, but I do want to mention them. So there is 1115 demonstration waiver, there is the managed care authority, there is home and community-based service waivers, state plan and home community-based services, community first choice option, and health homes. Those are all pieces that can be used to do different things through the Medicaid program. There's been so many advancements recently in Medicaid for mobile crisis and community violence intervention, which we're going to talk about, but also for housing, food nutrition, as well as new work related to reentry in terms of covering people 30 to 90 days prior to leaving jails in prison through waivers. So just a lot of opportunities and a lot of new opportunities. If you were familiar with Medicaid a couple of years ago, there's new stuff going on now. So I encourage you to look into what your state is doing. So for the mobile crisis piece, the intervention services are provided through rapid response, individual assessment, crisis solutions by trained mental health and substance use treatment professionals, as well as paraprofessionals, which is a really important point here, to be able to address people who have a mental health or substance use disorder. So the mobile crisis teams can respond to situations that require services rather than the need for law enforcement. Some states have mobile crisis services through Medicaid waivers. So there's that waiver term again, but the American Rescue Plan, or ARPA, which is an acronym I'll use for this, is largely responsible for the increased funding for mobile crisis services of recent time. Through this new opportunity, there was planning grants awarded to 20 different states to prepare for implementation. And the state plan enabled states to draw down an enhanced match of 85% of federal medical percentage for 12 quarters, making it a really interesting thing for states. So if you're not sure if your state took advantage of this, I really encourage you looking up whether they did actually take advantage of that potential benefit. Important things about this is services must be developed through a multidisciplinary team that can include one licensed professional who can perform an assessment within the scope of their licensure. There's also other non-licensed professionals who can be included through CMS guidance and SAMHSA best practices. Peer support services are a piece of this. Several states, such as Georgia, have already embedded peer support as part of their crisis system through warm lines, crisis intervention, and respite care. So certainly some great examples out there. To qualify for reimbursement, there must be training in trauma-informed care, de-escalation, and harm reduction. There's also opportunities to pay for transportation, but this is pretty state specific because some states have different legislation on who can transport to what, but for some states you are able to pay for transportation to crisis stabilization. And then the other pieces we wanted to flag is really screening and assessment and stabilization through telehealth is also available. So something to think about for rural and frontier community as an additional opportunity. The last piece that I wanted to touch on with the mobile crisis response is how to consider the post-crisis period. So this could be 24 or 48 hours for post-crisis, but different states have waivers that can be longer. In New York State, it's up to 14 days for behavioral health care additional for post-crisis services. And the other thing to consider is that behavioral health capacity and data sharing across systems is another function of which you can use, which could include hospitals, Medicaid, and other specialty providers. So now just to move on to the last piece that we wanted to share with you today is really focused on Medicaid and community violence intervention. So Congress and the Biden administration have really expanded the opportunity for community violence intervention, or CVIs, to be funded through Medicaid as a potential mechanism. And so there was guidance that provided that Medicaid could be a part of this, and there's several ways of doing that. One is through hospital-based community violence intervention programs, where that can be really supportive of this. There can be updates to the state plan benefits, so you could actually work under a number of different criteria there to be able to do this. A big piece of this is through options related to preventative care. So different opportunities through prevention include violence prevention to prevent disease, disability, or health conditions is a big piece of this. So violence prevention would fit under that umbrella. There's a set aside opportunity through the Affordable Care Act of 1% related to prevention. So that could include these services. Something else important to point out is some licensure of other licensed practitioner, and licensure is not federally required, but you do have to define what those unlicensed practitioners would do. So lots of opportunities for things that are already going on amongst community violence intervention across the states. Other pieces is under rehabilitative services, health homes, different waivers as well, really could be used to fund community violence intervention. So we do not have time to go into all the details today. Happy to follow up with anyone that has questions, but really excited to hear from our local team about the great work they've been doing.
Thank you. Thank you, Sarah. That is really helpful context for the moment that we're in. And that's, what really brought us here together today, is to talk about how these different new opportunities, this really complex and kind of fast moving landscape, can be leveraged by different jurisdictions in order to better support the programs and services that they're developing for to scale up and for the longer term. I want to go next. We're going to zoom out and then we're going to zoom in. So I want to go next to Alicia, and what I'd love to talk about is you know, with all of this background, with all of this information and kind of all the different terms and the different types of waivers, where do you get started if you're a jurisdiction that is standing up a program or looking to change funding sources? Where do you begin?
Sarah, I thank you for doing such a great job summarizing at the highest level what it is that Medicaid tries to accomplish. I'll try to bring it down a little bit, and forgive me in advance for forgetting to spell out acronyms. But I think one of the things that's important to know is that when it comes to Medicaid funding for crisis response and where do you start, it's best to start with an understanding of what we refer to at PEGS as behavioral health emergency services. So you might hear me say BH for behavioral health, or BHES for behavioral health emergency services, or in some cases, BEAR, behavioral health emergency response. But start with an understanding of the services and benefits currently covered by Medicaid in your state, and expect that those services are not the same ones you would necessarily associate with being called crisis. As Sarah mentioned, keep in mind that Medicaid is a public health insurer and that states do not organize behavioral health services in the same manner as other states. And to look at things like provider manuals and benefit descriptions that are written in layperson's terms. Sometimes it's even hard to contact Medicaid because you don't know who in the agency to speak with, and there's such high levels of specialization. It's hard to be able to get a quick and clear answer to your question. So start with asking statewide trade associations, not to endorse any of them, but for example, there's the National Council for Mental Wellbeing, where there are state affiliates and specific state chapters or councils for that same association, or the Mental Health Corporations of America. Starting with information at that level can get you some insight into what your state Medicaid program covers and how it's constructed. And looking at things like Kaiser State Health Facts and other general information from the Kaiser Family Foundation as one example, just to get a better understanding of Medicaid generally. There are also other national organizations that do great job at publicizing materials, such as the National Academy of State Health Policy, or NASHP, or the Center for Healthcare Strategies, and even large healthcare consulting firms will put information out around behavioral health emergency services, or what we typically refer to as crisis. And what are the questions that you should ask? So I would suggest that you find out whether your state Medicaid program covers services. So we talk about crisis and we talk about emergency behavioral health emergency services, but keep in mind as a health insurer that Medicaid is really paying for those interventions. So asking about whether your Medicaid program covers services like screening, risk assessment, triage, de-escalation, stabilization, comprehensive evaluation, extended observation, care coordination, and initiation of treatment for individuals experiencing a behavioral health emergency is a good start. Ask if those same services are covered in a myriad of settings, including telephonically, in the community, and in an office-based setting, and in more comprehensive institutional settings like hospitals or receiving and stabilization centers. And then also find out if the types of clinicians and credentialed paraprofessionals who can render those services, as well as the organizational eligibility requirements to be enrolled as a provider entity in that state. And another question is to find out the payment methodology or the pricing method and covered components of those services, such as on-call cost for those differential costs related to expedite a rapid response, and also find out what non-covered intervention and non-covered settings are. All of those things were useful for your understanding of how to relate Medicaid as a health insurer to the types of service packages that you may, in other terms, call mobile crisis: screening, risk assessment, triage, de-escalation, stabilization, comprehensive evaluation, extended observation, care coordination, and initiation of treatment. This is just a handful of the types of service interventions that would be available to a person in a behavioral health crisis. And again, enumerating what Sarah already mentioned, how does this vary by state? Every state's different. Some states maintain responsibility for establishing services, provider network requirements, and setting payment rates for behavioral health emergency services. In other states, the Medicaid program contracts with Medicaid managed care entities, which might have no or limited authority to deviate from what Medicaid requires in terms of how to pay for or describe that service. Or that same managed care entity might have broad flexibility to accomplish the service delivery goals in a manner that the health plan determines most appropriate. And keep in mind that not all managed care entities may elect to use the same provider network unless contractually obligated by the state. So the state mental health authority, as an example, might deem a crisis provider eligible to deliver a mobile and crisis stabilization service consistent with state licensure and certification requirements. However, a Medicaid managed care entity may opt to contract with a entirely different organization that not only delivers the behavioral health emergency services, but also, for example, might provide an extensive array of services to facilitate care transitions up and down the continuum. Again, happy to provide some additional insight on this topic, but hopefully that's a good starting point for this conversation. Thank you.
I had a follow-up question for you, and I was wondering if you could just break down what you meant at the beginning when you said that the health services or the interventions that are covered may not necessarily be what you think of as crisis response. And that seemed important because it sounds like, you know, a match has to be made between the response that's being provided and what is actually covered. And maybe how we think about those things or the language that's used is important to work through in order to find that match. Could you break that down a little, or if you have an example that might illustrate it?
Absolutely. So the reality is that crisis as a need is not new, but the focus on crisis services and what it is that we all seek to have paid for differs when we talk from one state to another, and in some states within one part of the state versus another. So when we say things like crisis stabilization unit, as one example, it might mean something in Ohio that means something entirely differently in another state. Even within a state, a crisis stabilization unit might refer more to what happens after the crisis, which is kind of antithetical to the word crisis. But we can't utilize the same words and expect for all of us to have the same meaning or intent. But diving into the description of a service as promulgated by Medicaid kind of help you get a little bit to that level of clarity. So don't just pay attention to the title, the service title. Also pay attention to what that service title includes as a description. What are the covered interventions? What are the covered settings? What are the allowable and unallowable cost and clinicians that might be delivering a service? Hope that helps, Freya.
Yeah, that is really helpful. And I think that provides a good segue for us to now talk about an example of a partnership in action of doing this work and seeking the Medicaid reimbursement for provision of crisis response and related services. So I'm going to go now to Jason and Joe from Thurston Mason. And could you walk us through, you may want to start with a little bit more background about your organization and really the services that you provide that are supported by Medicaid, and what are the major steps that you had to take in order to receive that reimbursement and to become covered in that way?
Thank you, Sarah and Alicia, for explaining all of the 30,000 foot level and maybe 10,000 foot level aspects of Medicaid. It can be very complicated, to be sure. And so I'll start with our state is a managed care state. So the Medicaid flows from the state health Medicaid authority, which is the healthcare authority in our state, to 5 different managed care organizations who then contract with provider networks to deliver those services. However, we also have regions that are that have delegated behavioral health, they call them ASOs, that's Administrative Service Organizations, of which we are one, where we have a contract with the Healthcare Authority, as well as with some managed care organizations for some crisis funding. So we're a funder. And then on the other side, with Olympic Health and Recovery Services, we're able to do direct service specific to crisis and some other jail-related jail diversion programs that we do as well. So we were already in kind of a better spot than maybe some agencies to start with, because we had the knowledge of what services were eligible under Medicaid. And that was key for us because we do not have a waiver in place in this state, which Sarah talked about, which would be fantastic if we did. That specifically allowed for Medicaid services to be billed to civilian non-police response for crisis. So we had to work with what is allowable. That was the first step, is seeing what was allowable, what codes are reimbursable, what were the staffing models that could be reimbursed and under what conditions. So that was a big piece of it. And then after we did that and saw what was billable, then it was really about meeting with the local jurisdictions. And I'll let Jason talk about that, because in the end, Medicaid is really still only going to be anywhere between 40 to 50% of your costs for these programs, because not every service that is provided by a mobile crisis team is going to be billable to Medicaid. And many of the individuals that you're serving are also not going to be Medicaid eligible. So I'll let Jason speak to some of the work we did with the local jurisdictions for that piece.
Yeah, so it's foundational to make sure that anything that we build is going to be meaningful to the communities that we're trying to serve, right? So this is one small part of the crisis continuum, one part of criminal legal diversion, that it was really important to work with local government, local stakeholders. And initially we started with a local jurisdiction here coming up on about 3 years ago to develop the initial model for what would be a meaningful response, with the acknowledgement that law enforcement, although they get a lot of the calls, are not the best response when we're talking about behavioral health issues in crisis. And we had pre-existing relationships with these agencies, because a lot of times law enforcement were referring to the mobile crisis that existed, or reaching out to our designated crisis responders for involuntary treatment evaluation. So some of that relationship already established to build upon. And from there, it was just really important to kind of talk to them about, this is what we can provide. This is a model that we think makes sense. And like Joe mentioned, we can draw down some Medicaid to help sustain and offset some of the cost, which benefits them, but also benefits our larger crisis system, because it enables us to more fully capture the true cost of crisis that we're providing for the local region. And then to offset the non-Medicaid, like Joe was talking about, that has to go into this with local funding, they're invested in these programs and essentially own a piece of the work that's being done in the community.
Can you talk a little bit about how the requirements in order to become eligible for Medicaid reimbursement, how that really informed or shaped the way that you presented kind of what were the services that you could provide to the jurisdictions? Like to what extent they kind of have their needs and you say this is what you can do. What was that process like of finding where you could maybe meet in the middle, or if there was kind of a perfect fit between what you could offer and what you knew was reimbursable and what they were seeking?
Absolutely. So first, in our state, and I think in most, in order to get reimbursed for traditional Medicaid services, that typically has to be run through a licensed behavioral health agency. And so in the initial meetings that we had with our local jurisdictions, some of them, they were also interested, but in having staff that were employed by their agency or contracted individuals. And so what we offered was going through a licensed behavioral agency that's able to bill Medicaid, allows for more encounters or more services to be billed under that, which then in turns, and Jason I think alluded to it a little bit, actually helps build the Medicaid rate. It increases the rate because you're reporting in billable encounters, which then increases more Medicaid back into the system with utilization. So we talked about that and then the caveats that come, or the additional bonuses that come with having staff that are, non-police, that are civilian responders, but embedded within a jurisdiction. They're still employed by the behavioral health agency, so they're able to to bill for those services. But they, in effect, are staff of that law enforcement jurisdiction, and they are dispatched and deployed by those law enforcement entities many times in place of law enforcement response. So it was that kind of combination, and then and frankly, it was more people. While the law enforcement could really afford, within their budget or whatever grant they were looking for, was maybe one person, with our Medicaid balance, we were able to fund 4 people to cover 7 days a week, about 10 hours a day is I think what we're looking at right now in our current model, with 4 different law enforcement jurisdictions. So it just provides more coverage, provides safety, and provides in that the folks go out in pairs, and it aligns with SAMHSA's best practice model. Did I answer your question?
Yeah, that absolutely does, and it touches on where I wanted to go next. So we wanted to talk about to help give folks a sense of what are the different types of calls for service. We may think of community needs in terms of what are people calling for help for, what are they reaching out or calling 911 for, and in the programs that you work with, in the jurisdictions you work with, what are the types of calls that you are sending out teams that are in part supported by Medicaid? What are the types of calls coming in that they're responding to? And also, could you talk about who are the workers going out on those calls? You talked a little bit about how these teams are, made up of jurisdictions, direct employees and embedded personnel, but kind of who are they, and to what extent have you also seen an expansion of the types of roles that you can include on those teams?
Sure. Okay. So the calls they range from somebody who is calling 911 because they believe that their loved one, might be depressed and might need an outreach, or someone to go check on them. We get those kind of calls quite a bit. Or it could be my family member has dementia, or is having some sort of behavioral health crisis that we need law enforcement involved. They ask for law enforcement because in most parts of our state, although 988 is up and going, or trying to get up and going, people still call 911. And so having our folks embedded there, they help in working with their jurisdiction. Those calls are triaged, and then 8 out of 10 times the civilian responders are responding independent of law enforcement. It's only in the cases of where there might be a safety concern, where somebody calls and says, my family member is behaving erratically and they have a weapon. That's the only time that we ever have law enforcement respond. And so the folks that we have are a behavioral health clinician who's able to be reimbursed for clinical services. This is usually a master's level clinician, master's in social worker or counseling psychology. And then their partner is usually a certified peer, and Sarah kind of alluded to that in her presentation. And peers are individuals with lived experience, and typically are in recovery from either a substance use disorder or mental health disorder, or both, and have been specifically trained to engage in de-escalation and engagement with individuals who might be in crisis. And that's been a fantastic approach, to have both the clinical person, they're able to do the risk assessment and screening, but then also having the certified peer who's able to do the more engagement, outreach, and basically the caring, empathetic part of that outreach. So in tandem, it's been a really nice way to do the outreach. And until January of 2024, and this is some of the work we did with our state partners, we weren't able to bill for the peer services for that specific crisis encounter. So we needed to use other fund sources, local fund sources. in 2024, the peer crisis outreach is now billable as a Medicaid service in Washington State. Our state Medicaid authority changed the state plan, but that was work that we did with them. So to Alicia's point as well, it's working with your state Medicaid authority to get the right service for each region.
I would just add a quick plug-in about peer services and how successful that's been with both engaging people and helping them move towards stabilization, and also in shifting the culture to some degree, both in general within the crisis services system and also in interaction with law enforcement. Having certified peer counselors and elevating the peer role has been a huge success for our organization, and I think the local community as well.
Great, thank you. And that is excellent news that you're now able to include the billing for peer support. And we're seeing that more and more jurisdictions across the country are starting to include peers on their teams as well. We're gonna go next to get a little bit deeper into some of the challenges and limitations, and why it's worth it to persevere through them. I'll turn first to Alicia, if you could share some of your thoughts on that. And then before I do, I have noticed a couple questions in the Q&A of folks asking if this is going to be recorded. It's definitely going to be recorded, and we'll be sending it out within a day or two, along with any other links or information that anyone participating today wants to have included. So that will be coming. But so Alicia, if I could go to you next, and you could, from your experience in different jurisdictions and states and types of providers you've worked with, what are some of the common challenges that folks are running into, and what guidance would you have for working through them?
It's similar to what Joe and Jason were just referring to. It's not always having payment, long-term sustainable payment for those services that are not Medicaid coverable. And it's great problem to have with a robust financing coming from all sorts of funders at this point, ARPA, you name it. But those have an endpoint, and they're not necessarily going to be continued, especially in the same manner that they were initially awarded. And again, the other one is just the complexity of, we have such a litany of terms that we use that from one provider to the other, we don't know what it is that we're delivering, and it's hard to provide some predictability about what the likely outcomes are. So having a dearth of kind of baseline metrics and then clarity on what the outcomes ought to be to demonstrate success.
Could you go into a little bit more detail about what you mean with respect to clarity on outcomes and demonstrating success, and what are ways that, let's say, a new program or service that's getting started up can do that in order to ensure that they are set up for the long term, to be sustainable and to have their services covered to the maximum extent possible?
Right. So when we think about crisis services, we have to consider that it is part of the continuum of care that a person with a mental illness or substance use disorder it uses over a time. So there's times of wellness, times of crisis, and times of somewhere in between. The crisis provider outcomes can't just be limited to, I've made my response and I've gotten the person stabilized and off the street, as one example. I've taken them from the setting that was not the best to another setting, and then there's no follow-up. So what was the ultimate outcome? Did that person get a transition to a level of care? Was there a warm handoff? Did that person recidivate back to that provider? It's those kinds of outcomes that need to be established, ideally by the state, but absent that, as providers set up their programs, there ought to be some theory of changes in terms of, we exist to do X, and we can demonstrate X by documenting whether it's reduced time to respond, reduced interactions, over time. Connection from this person was never part of a community behavioral health system, and now they are. Just there, I'm sure Joe and Jason have way more examples than that, but just a few.
Yeah, I think it's been really important to show that we're connecting people to other services for ongoing stabilization and being able to demonstrate that. You know, a lot of Medicaid is based on kind of fee-for-service reimbursement, and this is a lot more than just, you know, you provide this service for this period of time. There's a lot of ongoing work that happens and care coordination that's not always reimbursed. And like we just talked about, you know, showing reduced calls to 911, reduced crisis utilization, looking at all those kind of impacts, positive impacts for the community is really important, both in demonstrating just the overall success, but in maintaining the engagement of the community and the stakeholders to support the work ongoing.
Great.
Thanks, Jason.
Oh, did you have something, Joe?
If I could, it's also tracking what's important for each jurisdiction too. And to Jason's point, it's, you know, I know for one of our teams, they responded to over 3,000 calls, 3,000 outreaches this year, or in calendar year 2023. And that's almost, and I think the police only had to respond to less than 500 of those calls. So that's over 2,000 calls, 2,500 calls that would have been typically law enforcement response that is now our civilian, you know, first responders or civilian crisis responding to. So that means something to each jurisdiction, and it helps build. Okay, for each jurisdiction, this is a good investment of the resources that they have, the non-Medicaid resources they have to put into this.
So I want to stay on the topic of challenges just for a second, and then I want to make sure we save time to talk about private insurance. And some of the questions, I'm trying to be responsive a little bit to what people are sending in, are, does the individual, the patient, need to be on Medicaid in order for you to be reimbursed for their services? That's one question. Also getting some questions about kind of the burden of the billing, and can you talk about kind of what's involved in that administrative lift, and then anything else you want to kind of throw in about, you know, logistics of billing. You know, how does that work? It's not obviously really possible to get, I'm sure, all the information you need during a crisis related encounter. So if you could touch on kind of that collection of things briefly, and then I'd love it if you could then start to talk about your plans to start billing private insurance and how that's going to work.
I'll hand it off to you, Joe. I think.
Okay. Sure. So the person that's receiving services does not have to be on Medicaid, but they have to be Medicaid eligible. And so typically what we'll have is if our crisis team, has an intervention with someone who doesn't have insurance and is not currently on Medicaid, but it appears that they might be eligible, they will do a warm handoff to either a local agency or even within our own agency to help that person get connected to Medicaid. And then those services are usually retroactively billable it depends on when we get them in, but it's usually within that given month. We can do that if we get them quickly. So they don't have to be Medicaid at the time, but we need to get them signed up as quick as we can in order to bill for that initial service that we did. But yes, otherwise, yes, they do have to be. And then the question about the Medicaid billing, yes, it's a bear. It's a lift for sure. But it's not one that most agencies or all agencies that are currently contracted with for Medicaid services, they know how to do that already, and usually have dedicated support staff or and a billing staff to be able to make that happen. But that is certainly a lift if you're just starting this out, to consider for sure.
It's about documentation too. Documentation is slightly less on the crisis services side, but there is still a lot of documentation requirements for Medicaid billing, like there would be for any other kind of behavioral health service.
Thank you, Sarah.
Yeah, I would just add that I think you should consider whether your agency needs to become a Medicaid biller or not, because you can also partner with different organizations in your county or local government or other behavioral health providers that might already be billing as a part of this. So I think you should think about what partnerships make sense that you might already have in place. It might make sense for your agency to become a Medicaid biller, but it also might make sense for you to leverage additional resources and partnerships to get to that mechanism. And I think that's really important for people who might be outside of the healthcare field and you're trying to learn more about it, is first talk to other local agencies that are doing this type of work to really get information.
Thank you. That's a great point. Okay, so for the final segment, I turn it back to Thurston Mason, and can you talk to us about your work with private insurance?
Sure. So our state legislature passed House Bill 1688 in I think it was 2022. That, and I believe we're the first state in the nation for that would require commercial carriers to reimburse for mobile crisis services. And there's a couple of specific codes in there, and I'm happy to share the legislation about what they refer to. But it is the mobile crisis services that are being delivered on the publicly funded side. So that does align, and that starts this year. So we are currently in negotiation with 19 different carriers to be able to submit claims on behalf of the members that are being served and provided crisis service. So I should have an update on this later in the year on how that's going. But right now it's about making sure all those contracts are in place, making sure that the eligibility requirements, and there's so much work behind the scenes that goes on with commercial that's even seems to be more complicated than Medicaid, but it did take legislative action to make that happen in our state. So.
And in terms of your expectation for how this is going to help fill in your funding streams, do you have kind of a projection of, how many people for whom you're going to be able to collect on through private insurance, and kind of, what led to wanting to pursue this? Because it is, as you say, not commonly done, or maybe first in the country.
The argument that the state, or that we helped the state make in seeking this legislation, was that the state was already paying for these services via the non-Medicaid supports that go in to help the crisis system be fully funded. So just as an example, right now, if our crisis team provided a service to someone who has, I'll just call it out, United Healthcare, we cannot submit a bill to United Healthcare for that service, and it's then covered and paid for by state funds. So that was part of the reasoning for the state working with the Office of Insurance Commission to build that legislation. In terms of what does the volume look like, in working with our state partners, I think they estimated that just under 20% of the crisis services that are being delivered statewide might be eligible for reimbursement to commercial carriers. So we don't know what that looks like in our region, because we've never collected that data before. So it's always just been about non-Medicaid versus Medicaid. So a lot of this year is really, for every region in our state, is going to be looking at what does that utilization actually look like? How successful are we going to be in submitting claims? How many times in claim submission, or how many times do we have to submit each claim in order to get payment? And then what does that payment look like? So this is going to be a real working year for us on how do we get all the kinks out of this? But still very good. With most of the commercial carriers that we're working with are nationwide. So our state will be the guinea pig on this, but hopefully we'll have a model that can be replicated in other states, and we'll have lessons learned.
Great, thank you. I know we'll be watching you closely, and wishing you lots of luck throughout this process, and looking forward to getting an update on it. So I'll turn to our last question, which is for all the panelists, and like to know what your one piece of your recommendation or piece of guidance or advice would be for a jurisdiction that's just either starting out alternative response services, so kind of at the beginning, and has the opportunity to build something in or be structured in a certain way, and also or for those that are kind of at this pilot stage where they're transitioning from this proof of concept, they've done it in a, with kind of big, a small region of their city or town, or only including certain services, and haven't necessarily put in long-term funding and things like that. So making that transition to become a sustainable program, what would your advice be? And so Alicia, I'll go to you first, and then if we could go to Joe and then Jason.
I think a couple things come to mind. One is write your story down and tell it to whoever will listen, and use just the most basic of terms. What problem were you trying to solve? What did you actually do? What difference did it make? And if you can quantify the difference, that's awesome. I would also get to know in your area, who are the partners that are involved in similar work, either as providers, to Sarah's point about partnering with someone so that you don't have to initially step out and do the Medicaid billing, or as payers, payers including local communities who are also having to build up their capacity for making sure that these services exist. Obviously, the Medicaid health plans, those, don't underestimate the likelihood that the services that you provide are need by many of the folks in your community, and especially at the public insurance level.
And I'll just reiterate what Alicia said. It's the partnerships are key. Many of the folks that utilize the crisis system are also touching other systems within the region. They're at the hospitals, they're in the ERs, they're in your behavioral health provider system. So having that collaboration and having the partners working together to figure out what is the best way to serve these individuals and how do we make this happen. Everybody has access to a variety of different fund sources, whether that's grants or Medicaid or ARPA or now commercial insurance, has the same goal of helping these individuals out, reducing the need for first response, and then helping them have long-term sustainable recovery. So that's really key for us. And our relationship, since we've had these non police response programs going for the last couple of years, our relationship with each jurisdiction has been so positive, because before, when we didn't have these going on, it was police didn't know what we did. There was a little bit of fractured relationship. It definitely was not the way that it is now, where we actually have in one of our teams, the police chief gave all of the crisis workers letters of commendation within the first 6 months of them being, involved in the service, because of how well it was working and how much it was needed. So it's just been a really positive partnership thus far. So that's what I'd say.
Yeah, I would echo that, and get help. Reach out to other people that have been successful and done this work to get inspiration and ideas to learn from their mistakes. This is a small, like I mentioned earlier, this is a small part of the overall crisis continuum and the overall behavioral health system. So develop those relationships with all the partner agencies and programs that are going to help somebody reach stabilization and sustain recovery and success. Somebody mentioned in the chat that we have LEAD in our region, law enforcement assisted diversion, and we do, and that's been a huge resource for these teams to have someone to hand off to for long-term ongoing case management. So make sure that you have a full safety net as much as possible, working with other partner agencies in your community to help people achieve full success.
Okay, great. Thank you all. Thank you for taking the time to talk with us today and to help share your experiences working with Medicaid and with private insurance. And thank you to our co-hosts, to Vera and to CSG. You can find more information about the policing projects, Reimagining Public Safety project, at our website, safetyreimagine.org. And we'll also be, as I said earlier, sending out this recording in the coming days, along with some additional information that was mentioned and some important links. So thank you again for attending.